Hey guys, with this current coronavirus outbreak, we thought that it was important to standardize the process of some of our complex procedures to decrease our risk to staff and patients. During this video, we're going to talk about intubation. This is our current guideline regarding intubation for COVID suspected or confirmed cases. This is always subject to change as more evidence comes out. During this video, we're going to only talk about the bottom left section, the pre-oxygenation section, and we're going to take a look at some of the devices using video clips so that you can become a little bit more familiar. The first device we're going to talk about is regular nasal cannula. This should be considered when the patient has reached 5 liters nasal cannula and are still having issues with oxygenation or dyspnea, or you suspect their clinical trajectory is such that they will need intubation, but you are still able to oxygenate them with the nasal cannula. We recommend putting a standard medical mask over the pre-oxygenation device on the patient's face if it'll fit, using whatever pre-ox device that you're using, which would work great in this case, or high-flow nasal cannula. With standard nasal cannula, we're recommending use of 10 liters per minute of flow for pre-oxygenation. The second option in this list is for more hypoxic patients, and it's supposed to be sort of a substitution for your normal flush rate O2 through a non-rebreather with a bag valve mask setup that we think will decrease contamination and exposure to our staff. For the sake of this video, we've taken these items out of their standard packaging, and actually in the emergency department, we have several BVM kits that contain these components. Make sure that when you're assembling this device that you really snugly and securely attach these things together so they don't come dislodged when you're using them. Turn the O2 up to flush rate, which means that it's making a loud hiss. When we're using this device, we're not squeezing the delivery bag. That's thought to aerosolize more particles. The patient should be breathing spontaneously with a good mask seal. This depicts the best technique, two-handed technique for creating a good mask seal. There are some straps that will attach to a BVM mask, which we don't currently have, but we don't recommend using the CPAP or BiPAP mask because that has some release ports on the front of the mask that would be before the viral filter. As an adjunct, you could put in your bag valve mask setup an capnography waveform device so that when you're having good face seal, you'll see a nice square and tidal tracing. Then finally, you'll want to dial in your PEEP using your PEEP valve to 5 to 10. The final device is the LMA device, which is for profoundly hypoxic or apneic patients, and we recommend paralysis before use of this device. This is also the preferred reoxygenation device when you are already attempting intubation. The reason we chose this device over the eye gel is because it allows better adjustment of cuff inflation, and the metal handle allows for better repositioning against the glottic structures. Andy didn't let us practice this device on him, so you'll just have to use your imagination here. Use the metal handle to make micro adjustments in positioning and lift towards the ceiling for a better glottic seal.
Thank you guys for watching this video. We are looking forward to your feedback on our strategies here. And obviously this is all subject to change in the near future as more evidence arises or equipment shortages happen or patient volumes dictate that we change things. So stay tuned.